Hello, everyone. Zane Horowitz and the crew at the Oregon White Center with the June 2025 Visual Journal Club here with a few visual clues to some of our articles. We'll be talking about toxins that affect the pancreas or affect blood sugar, either high or low. So, general grouping that's not covered in a lot of places. And we'll be doing a little bit of a tour of different places around the world. And our first stop is Trinidad, a tiny little island in the Caribbean, and this creature, the Trinidadian scorpion, Trinidaditis trinidaditis, is our first article we'll talk about. This is often when you're doing rounds on medicine wards and the attending goes, well, what else causes pancreatitis? Oh, scorpion bites. Well, I'm going to say that's probably only true if you're in Trinidad. Let's see, Marla. Go ahead, Marla, tell us about this article from 1970.
Yeah, it's definitely a classic. And this is interesting because I've actually been to Trinidad and I've seen one of these.
Oh,
Luckily did not get stung after watching this or after reading through this article. So with background, as you mentioned, scorpion stings or this particular scorpion, the Titis trinitatis. I've practiced that about 10 times. That species constitutes about 90% of the scorpion population in Trinidad, and consequently, scorpion stings are very common in Trinidad, actually, and especially from this particular species. It's the most common cause of pancreatitis overall in Trinidad. As far as what I came across. And so the objective of this study was to kind of describe the clinical presentation, biochemical findings, and outcomes of patients with these scorpion stings, confirmed scorpion stings. And so going over methods, they brought in only 30 patients, so 20 male, 10 female, wide range of ages, 9 to 57 years old, with definitive stings from this particular scorpion, and they measured serum amylase, CBG, ALT, and bilirubin on arrival, and then watched them overnight and got those same labs the following morning. And they also did urinalysis for glucosuria and proteinuria. So then looking at the results, if you're, initially looking at the clinical presentation, so what they saw with these people that came in with these stings, something that they noticed that I thought was interesting that they found specific enough for almost a spot diagnosis preliminarily would be an increase in salivation that happened in just over 50% of the subjects. Abdominal pain actually was pretty similarly distributed, only about just over half experienced abdominal pain. Is typically epigastric, radiating to the back, so typical what we think of as classic pancreatitis abdominal pain. And that developed within about 30 minutes up to about 5 hours after sting. And then non-vomiting happened in about half as well. And most of these symptoms, pretty much everyone they said resolved. All symptoms had resolved by 24 hours later without, in this particular cohort, any major complications like shock, jaundice, hemorrhagic pancreatitis, cyst formation, anything like that. And biochemical findings, the other objective they were going after here, they were they noted out of all the things that they were measuring, so the amylase, CBG, ALT, bilirubin, they noticed that they found an increased amylase in 80%, and as soon as 1 hour post-sting. However, about 30% of those patients with an increased amylase had no abdominal pain. So maybe a little bit of painless pancreatitis, possibly flying under the radar in this particular cohort. And then, but as far as other labs go, like a little bit of elevated ALT in like 5 patients, no increases in ability. They didn't even mention the rest of the urine stuff because it didn't really show a whole lot. So, and then of note, they didn't mention anything about the repeat AM labs and how things really changed over time. Just kind of the initial, as far as what I was able to gather. But so kind of discussion and takeaways here. So acute painless pancreatitis from scorpion stings, particularly this scorpion, could very well be underdiagnosed given the fact that a lot of these patients didn't have abdominal pain. They were found to have increased amylase, otherwise indicating some level of maybe mild pancreatitis. And it's also important to note that abdominal pain severity did not correlate with amylase levels in these patients. And then the kind of biochemically mechanism of action that they were talking about, but trying to elucidate here in the article as well in discussion, was that it may involve, or the scorpion sting may have like a direct enzymatic pancreatic injury, maybe also some neurogenic stimulation that can lead to pancreatitis, maybe some like increased vascular permeability, secondary to like smooth muscle stimulation, hyaluronidase, trypsin activation, all of these things kind of down into what we now understand is like pancreatitis pathophys. And it's and it was also noted that there's no immune tolerance to the toxin. These stings happen all the time in Trinidad, but people that have been stung before came and they still had, they still developed pancreatitis in some cases. So that led me to believe that there would be like very minimal immune tolerance to this particular toxin. And limitations, though, there were a few here. Small sample, of course, 30. So a little bit of reliability, so, but still interesting. And then they also had a very short follow-up, right? And then they didn't really mention a whole lot about the follow-up labs. Only 24-hour follow-up. No mention of the AM labs. So it would have been interesting to see maybe a little bit longer term. Were there any long-term complications of this? Even though pretty much everyone's symptoms resolved over 24 hours, would have been great to see a little bit more long-term follow-up there. They're also very limited labs, and I did look up why amylase versus lipase, because right now we would initially get lipase, but it turns out back in 1970, amylase was the go-to for working with pancreatitis, and it wasn't found out till later that lipase was actually more specific. So as far as standard of care was in 1970, amylase was the go-to. And those are the main things that I was getting there, and I want to say things takeaways. So even if you come across a patient and you happen to have been to Trinidad and came in with a scorpion sting and somehow magically got a flight directly to Oregon, even if they have no abdominal pain, still work up.
So that answer to that question around is it's pretty unlikely that's ever going to happen. There's a lot of hyperamylasemia, and you're right, the widespread testing for lipase didn't happen until many years later. Just to note, some of the amylases in the study were as high as 3,000, so pretty substantial. I did find that this other places around the world have a similar scorpion, mostly in South America, but not in southern Argentina and Patagonia. So there's 3 or 4 other species. There was another paper from this century where they actually did measure amylase levels in a single bite in a case in Brazil, and their lipase level actually got up to about 2,000. So lipase is an okay test to do. It can happen, but it's mostly going to be people who are traveling from these other parts of the world where they may have pancreatitis. And again, it's very short-lived events.
Sorry, I just have a question. I'm curious because painless pancreatitis is an interesting thing, right? But they all had hypersalivation.
Yeah.
And that's where amylase is associated with hypersalivation. So I'm not doubting that people get pancreatitis, but I'm wondering if some of those painless pancreatitis patients just had elevated amylase because they were hypersalivating, or whatever is causing their parotid gland to produce more saliva is also producing more amylase.
Well, we go on a field trip to figure that out.
Totally. The other thing I will mention, we have had cases where people unpack their luggage from traveling somewhere and a scorpion come down and did medicate them. So while it's pretty unlikely that that patient on medicine rounds has pancreatitis from this, it is theoretically possible.
What I'm hearing you say is we need the prospective trial where we take a cohort and throw a scorpion at them.
Right, will you fly me to
Yeah.
hang out on the beach for a long time?
Drop you
There you
off.
go.
All right. Well, moving along to yet another toxin of somewhat obscurity, there was an infamous rat poison rodenticide known as Vacor. It's got a longer name, but most people remember it as Vacor. So we actually have two articles on it. One was this classic one, again, it's an ortho article from New England Journal from 1970s, 1980s era. And that was possible. I'll have Danny tell us about that one.
Yeah, so like Lee mentioned, so this article was published in 1980 by a Stanford physician. Begins by stating that Vacor is known to produce this syndrome that results in hyperglycemic ketoacidosis. And this physician wanted to study the quote, distinctive array of neurological impairments in 12 adults who had ingested the poison. He had personally evaluated 4 of the patients that he had looked at in this study, and the remainder were seen by other physicians who he then obtained a chart and essentially like a retrospective chart review on. So he provides 3 cases. The first case is a 48-year-old male who ingested 1.56 grams of Vacor and developed symptoms within about 45 minutes. His neurologic symptoms began about 2 hours after the ingestion and initially included leg weakness and some numbness, and at about 9 hours became reportedly lethargic. His vital signs were notable for hypothermia, orthostatic hypotension with a 50-point drop, so from the 130s systolic down to the 80s. And then his exam progressed to have some meiosis, some generalized weakness, absent reflexes, and distal hypoesthepias in his legs. As far as his lab workup goes, he had a leukocytosis of 16, a blood glucose of 130 with a ketoacidosis and a pH of 7.31. And he had some EKG changes with inferior ST segment changes and T-wave abnormalities. He later on developed urinary retention, short-term memory deficits, slurred speech, and an ataxic gait. He was treated with nicotinic acid, not nicotinamide, and insulin was used to control his hyperglycemia and ketoacidosis. On the 3rd day post-injection, he went on to develop some more generalized areflexia and increased sensory loss, but was no longer having sweating from his face and trunk, but was having it on his palms, which is super interesting. I don't know how I would explain that. On day 13, he developed hallucinations, changes in mental status, and he just essentially continued to decline from a neurologic exam standpoint with the development of some choreiform movements and myoclonic jerking. He had an EEG done that showed diffuse slowing. However, his labs at that time were normal from a metabolic standpoint. On day 15, he became gradually more calm and less confused with improved motor activity, but his memory was still impaired, and they reported that he had a impaired intellectual function over several weeks. He went on to develop some dysphagia, had frequent aspiration events, as well as persistent severe orthostatic hypotension. His new onset essentially diabetes required insulin administration, so it's insulin-dependent diabetes. And he ultimately passed away, and the presumed cause of death was hypoglycemia, potentially from insulin administration. The second case that he discusses is a 36 male, also took a 1.56 gram injection of Vacor. Symptoms began at 4 hours, where he had generalized areflexia, was started on nicotinamide, not nicotinic acid. And over 3 days, he developed myalgias, palpitations with some EKG changes reflecting atrial bigeminy. 4th day, he became lethargic, and on day 5, began developing orthostatic hypotension, ketotic hyperglycemia, and pancreatitis. His mental status reportedly improved after managing his ketosis with insulin. His exam then progressed to have some hand tremors, quivering, leg restlessness, and some worsening myalgias. as far as his neuro exam goes, he developed some anisocoria, horizontal nystagmus, some stocking glove hyposthesia, so similar to the previous case. And then his EEG showed metabolic encephalopathy, so also similar to the previous case. At 10 months, his reflexes returned, but he continued to have the hypoesthesias in his legs, and his his diabetes, new diabetes, remained insulin dependent. On to the third case. This is a 27-year-old male with a 0.78 gram ingestion, so half of the other first two cases. Who developed diabetic ketoacidosis. It sounds like on his initial presentation, he wasn't totally forthcoming with his ingestion. His exam showed some ureflexia, later dysphagia and diarrhea, as well as having ultimately developed orthostasis. He was treated with nicotinamide that was started on day 11. And similar to the first case, his orthostasis had like a similar 50-point drop whenever you go from like laying to sitting. And he had improvement in his dysphagia and diarrhea, as well as return of his lower extremity reflexes, but he had persistent leg weakness. They did a nerve conduction study. Yep. And they reported that his conduction velocities were slowed in the lower extremities compared to the upper extremities. So, going on to the discussion, in table 1, they show some of the characteristics of the patient's signs and symptoms with, and you can see like there's quite a bit of overlap. The hyperglycemia and ketosis is attributable to the destruction of the pancreatic beta islet cells. Patients with greater than 1.56 grams tended to have or 1.56 grams ingestion tended to have more severe neurologic impairment and encephalopathy. And there was one patient who died from persistent arrhythmias and hypoxemia, but their other patients seemed to have more like sepsis-related deaths. Autopsies were done in patients 6 and 8, and it was noted that patient 6 had no neuropathological lesions in the CNS or peripheral nervous system. But patient 8 had cerebral edema and changes in the spinal roots and biopsies. So I'm wondering, I don't know, and they don't go into it in the description, if patient 6 also had like a biopsy of his spinal cord and spinal roots, or if it was just patient 8, but I would expect in patient 6 to maybe also have similar autopsy findings. As for the autonomic impairment, most patients had orthostasis, with the biggest complication resulting in syncope. Several patients also developed this urinary retention. For the peripheral neuropathy, most had a loss of reflexes and diminished distal sensation, and their muscle biopsy showed some patients had like a neurogenic myopathy. As for the encephalopathy and dyskinetic features, half of the patients had CNS impairment, which ranged from either like a mild decreased alertness to almost a total comatose state. Some patients had ataxia and tremor and EEGs that were compatible with metabolic encephalopathy. Patients 1 and 4 had a late encephalopathy or tardive encephalopathy, which resolved to an alert state and global impaired intellectual function. They go on to talk about the biochemical considerations. So the neurologic mechanisms, they are super clear, but they reported that there's a decrease in norepinephrine excretion when patients become orthostatic, whereas you would expect kind of a bump to try to compensate for it. There's a suggestion here that Vacor is competitive antagonist of nicotinamide. And they mentioned 3 other cases of 3 children who ingested PNU or Vacor, and they got nicotinamide within 30 minutes of the injection and developed no sequelae from the injection. Other cases have demonstrated that administration of nicotinamide within the first day didn't prevent any of the symptoms. So they recommended that nicotinamide should be substituted for nicotinic acid due to its vasodilatory effects and less effectiveness. They also really talk about using fludrocortisone and compression stockings for some of these patients, and compared to another patient who had actually like far more improvement with hydroergotamine and fludrocortisone combined. They report that the patient with the ergotamine was able to resume his daily activities and
Yeah, this is sort of a very notorious rat poison. It was only on the market for a couple of years. It caused lots and lots of problems. Your other case as well. It's interesting, like this is written up from a neurology point of view. They basically don't go into a lot of detail about the diabetes, like each case ends with end of developmental diabetes.
Yeah.
Giving any numbers like that. But the treatment was also a very rare substance, which actually is not easily available anymore. And niacinamide or nicotinamide is the same, words for the same thing. It's sort of the amine of niacin, and it has to do with, instead of making good NAD, which is used for lots of process use, as we'll see in the body, it makes this VNAD, which is this Bacor adenine diamine. That essentially downstream effect and also neurologic function. So maybe central spinal cord, peripheral neuropathies, and probably other things as well. Obviously, in and of itself, Bacor completely destroys the beta islet cells, produces immediate, irreversible diabetes. And that was the reason it got pulled from the market. There, as we shall see, ate this as well. I gave you a second article only because I came across was like one of our adjunct faculty, Dan Spiker, had written it like 50 years ago. So I'll let you briefly tell us about this morbid diabetes.
Yeah. So this one, they present like a single case and then compare it to 4 other cases. The case here is a 42-year-old female in 1979, ingested 2 packets of Bacor, developed weakness and ataxia, abdominal pain, along with hand and extremity numbness. She had a glucose level of 722 and 2+ acetone in the urine. She underwent gastric lavage when started on nicotinamide. On day 3, she had some persistent neurologic symptoms, including numbness and weakness. And then she was intact from a behavioral standpoint, went on to develop some areflexia. Eventually also developed some orthostasis, anisocorin, lateral gaze nystagmus. She continued to have hyperglycemia and an A1C of 8.5, so diabetic. They kind of briefly have one-liners for comparison of the cases, and as far as the diabetes goes, they say it's consistent amongst survivors, those who have ingested Bacor. We also talked about some of the autonomic dysfunction, pretty much everything that we discussed in the previous paper, where people have postural hypertension or orthostasis with durations up to 10 months. They have these peripheral neuropathies, and then in regards to the lab data, all 4 cases that they were looking at showed hyperglycemia and ketosis. There was an elevated C-peptide and glucagon level in them. And they reported that the patient had normal thyroid studies and serum cortisol levels essentially within normal limits. So in regards to mortality, they attributed deaths to ketoacidosis or perforations throughout various regions of the GI tract and cardiac arrhythmias. And I think that some of the other portion in the discussion is that when Bacor was initially touted as this great rat poison, they had promoted it due to the fact that the LD50 or they thought that the LD50 would be similar to that in monkeys. So in rats, it's 4.5 mg per kilo. In mice, it's 80 mg per kilo. And in monkeys, it's up to 2.4 grams per kilo. In humans, based off of cases that we reviewed, it's 5 mg per kilo. So pretty much that of rats.
So you can extrapolate the numbers in different.
You're telling me people are more like rats.
Yes, they're our cousins.
Yeah.
One of the difficulties with animal models.
Grams.
Yeah.
Grams. Yeah. I wonder if that's how the box was in the first study, that number that the first 2 people took. I think that was what was in a box, and it was actually tasty because I think it was flavored as a peanut brittle kind of thing.
Delicious.
So kids would get into it. And
Delicious.
that was a very notoriously bad pancreatic toxin.
Rats
Yeah.
are the notoriously picky eaters.
Yeah.
The only good one's delicious.
Only peanut butter.
Yeah, I think the previous paper mentions, I think each packet, it's like 780 milligrams, so that's end up at like the 1.56, but yeah, crazy.
All right, well, thanks. Well, for our next article, we go on to another country in the Caribbean, Jamaica,
Absolutely.
where yet another toxin, which has a long name, but it's since been named hypoglycemia for clarity.
Obvious reason.
Colleen will tell us about.
So we've got a paper here in New England Journal of Medicine examining Jamaican vomiting sickness. So this disease, as just like a disease pattern, had been well described since the 1800s, and locally was associated with the ingestion of unripe or improperly prepared ackee fruit, but formally the cause and mechanism was not understood. The mortality rate in the early 1900s was like around or in excess of 80%. So if you got Jamaican vomiting sickness and it was significant enough that you showed up to a doctor about it, high rates of mortality. People would typically, as you would expect from the name, have nausea, vomiting, become very drowsy, potentially have seizures, coma, death. It was found when we were, able to test blood sugars that people were profoundly hypoglycemic. And then in autopsies, it was found that there was gross abnormalities in like liver histology, that there was a lot of like diffuse fatty infiltrations and like a microvesicular steatosis, which actually caused some like pediatricians, because it was unfortunately frequently children who got this disease, to suspect that Jamaican vomiting sickness might actually be the same thing as Reyes syndrome, which also caused people would have maybe some GI symptoms, but like alteration in mental status, drowsiness, coma, death, with this microvesicular steatosis. In the 50s, it was determined that unripe ackee fruit and the arils of the fruit contained two chemicals that were, the short name given was hypoglycin A and B, the full name being L-alpha-aminomethylene cyclopropyl propionic acid, which just rolls off the tongue.
For accuracy, we should continue to address it by the full name.
Absolutely. We're gonna go with hypoglycin. And based on rat studies where they gave these chemicals to rats, it was, the rats had the disease pattern that was seen in humans with Jamaican vomiting sickness, where the rats became very hypoglycemic and died. And it was thought that or was found in the rats that there was like a strong inhibition of long chain fatty acid metabolism with like suppression of like the mitochondrial oxidation, similar in some ways to the mechanism of action we see with like valproate, which also caused a microvesicular situation. And they looked at like the urinary dicarboxylic acid and like medium fatty chain urinary excretion in rats, and found that there was like, orders of magnitude increased excretion of a number of different fatty acids. So at that point, mid-50s, it was sort of tentatively thought that this hypoglycin A or B was likely the cause of Jamaican vomiting sickness, likely due to impaired or otherwise incorrect mitochondrial oxidation of fatty acids, but it had not been confirmed in any human cases. This article is a collaboration between a hospital in Kingston, Jamaica, and Yale, looking at, unfortunately, 2 fatal cases of unripe ackee ingestion by 2 pediatric, I think a 5-year-old and a 2-year-old. And they were able to obtain serum and urine concentrations from both children and do, gas chromatography of the samples looking for these fatty acid and dicarboxylic metabolites to see if they could compare it to the rats that had been given hypoglycemia A. So the case reports were that these 2 toddlers were totally normal in the afternoon before going to bed. They had been given lunch by a babysitter that initially the content was not known, but was later determined to contain ackee. Of note, ackee is like the national fruit in Jamaica, and the like national dish of Jamaica is ackee and saltfish, since it's very widely ingested. The next morning, difficulty arousing both children. They were like very much out of it. They started to have convulsions. They were brought to the hospital, and I believe one died like the morning after ingestion, and the second died the day after that. It sounds as though profound hypoglycemia was likely the proximal cause of death in both, though they don't really go into the specifics of it. The methods section in this paper is extensive and goes perhaps into more detail on gas chromatography than we need to at this point in time. But figure 2 of the paper shows the gas chromatographs of the urinary organic acids they had 5 American children that had not eaten any ackee fruit and that they kind of used for comparison. They also had urinary samples from 6 Jamaican adults who had eaten properly prepared ripe ackee fruit. And what they found for these 2 children that had eaten unripe ackee fruit versus the American children without ackee fruit and the adults with ripe fruit, that there were lots of spikes that were not present in either the 2 groups that contained a number of different urinary carboxylic acids. They've got a whole table, and in the like 4 normal children, they're like these aren't detected at all, and they are detected in relatively high concentrations for both of the ill toddlers. Interestingly, there was significant overlap in the urinary dicarboxylic acid seen in these 2 human cases and those seen in the rat cases, but they were not exactly the same. The rats had extremely high concentrations of 2 specific, short chain fatty acids that were present in the humans, but not to the same extent. And this was explained by saying that, well, much like we found with the Vacor, animals are all different from one another, and the way that rats handle the metabolism specifically they pointed out, isovalerate and butyrate are different in rats than in humans. So there's enough similarities that they're saying, yes, we have evidence both in humans and in rats that we are not metabolizing our fatty acids correctly. But there's a little bit of difference just based on the way rats usually metabolize these. Interestingly, they did find that while they the urine of these patients with the Jamaican vomiting sickness was very, very strongly acidic, in part because all of these short chain fatty acids that are being excreted, there's no ketosis, which was a way that in the 70s that this was being done. They were differentiating it from, say, a child who comes in very hypoglycemic, convulsions, coma, and acidic urine with large amount of ketosis, that you might say, well, does this child just have DKA? Because it's the 70s and maybe we're not catching, DKA in these children very early. But that was a differentiating factor. They also kind of looked into the thought that this could be Ray's syndrome, and determined that not only does, these children don't have the same prodromal symptoms that you see in Ray's, where Ray's is almost always preceded by some sort of viral illness that these children, do not have. But they also note that they had 5 patients with Ray's syndrome in New Haven that they got urine samples on, and none of those Ray's syndrome patients had any urinary dicarboxylic acids or short chain fatty acids. So clearly different underlying cause, even though they both end up with hypoglycemia and convulsions and coma and this microvesicular steatosis. In short, a very interesting sort of basic science investigation of what is going on in the urine of these humans, finding it is in fact extremely similar to the rats that were intentionally dosed with hypoglycin A, and providing very strong evidence for the first time that unripe ackee fruit does seem to be the proximate cause of Jamaican vomiting sickness, and it does seem to be hypoglycin A specifically, and that it does seem to be from inability to properly metabolize short-chain fatty acids. Which is really interesting. I think a lot of times, particularly for some of our less common toxins, we learn them today as and it's just hypoglycin A. But it took a lot of effort to actually just get the evidence to prove that that was in fact what it was, and to try to prove a mechanism behind it.
Yeah, it's a very specific. They identified this very rare toxin. Well, it's a rare toxin. It only happens in this one place, and not only is it just happened there, it only happens to eat the unripened fruit that's fallen off the tree to the ground and maybe is rotting a little bit, and emphasizing in this paper and elsewhere that ripe ackee is just fine. Says in the song Jamaica Farewell, basically, and so why study this? Well, maybe the reason is similar things happen in other places around the world.
And it was worth, definitively proving it's not the same thing as Ray's syndrome. And,
Which was common starting back then,
right,
late 70s.
Interestingly, I thought ackee fruit came to Jamaica and the West Indies from West and Central Africa, where it has been used God knows how long, but medicinally, it's not used generally as a food source in Africa, and so we really don't have reports of Jamaican vomiting sickness coming out of Nigeria or Ghana, even though this plant grows there and has always grown there. And it was only when it came to the West Indies and started being used as food that we started getting this illness.
Yeah, so it still pops up from time to time. There's been case reports in Ohio once and elsewhere where it's someone just bought something. In fact, someone gave us a can of ackee fruit, which is still sealed in our museum here. I assume it's the good stuff, but
the can decompressed. So that was not good anymore.
The can is gone, but we still got
We kept the
wrapper.
Yeah.
good.
I mean, correction, it may have been appropriately toxic at that point, but probably was botulism.
We have some left over.
Yeah, we got
Yeah.
some. You guys have some?
No,
The antitoxins.
Well, moving on to another part of the world and a slightly different but related instance, is why we studied stuff, because this is in the 2014 era in a corner of India up near the Nepalese border. We had another outbreak of something to do with lychee.
Yeah. So, this is.
I'll just point out, as opposed to the articles in the 1970s, we had one author of this article from the 2020s, about 30 authors, but I'm sure they all contributed substantially to the paper.
Now, to be fair, I do believe that they did. Once you guys, I'm gonna try to streamline some of these methods, like the New England Journal article. These guys went ham, and I love that they did, but it's a lot. But basically, what they have noticed, and this is really fascinating, was since 1995, up to the publication of this article, which is in 2017, there was annual seasonal outbreaks of an acute, completely unexplained, high mortality neurologic illness that primarily affected children and coincided with lychee harvest season. Basically, these kids would end up getting acute seizures, altered mental status, hypoglycemia, and usually really early in the morning. This over time had been associated with infections, pesticide use, lychee consumption, but no one had actually like confirmed any of these, and so there was just this widespread like fear, for lack of a better word, that this might just happen out of the blue. So in 2013, the Indian CDC and the United States CDC basically teamed up to try and investigate the illness and try to find evidence of what exactly was going on. Based on this weird pattern, this kind of annual, very seasonal reaction, they figured that this is much more likely an environmental exposure than infectious. So they specifically set out to try and test the infections, but also then to look more closely at the environment. And in particular, they noted that acufruit is a relative of lychee. And so they thought maybe there's a crossover here because in lychee there's methylene cyclopropylglycine, MCPG, which is very similar to one of the hypoglycin A and B type toxins. So what they did was both of the CDCs developed a case control study and just took a sampling from the local hospitals. There was 2 local hospitals in the area to basically get a general population view and then kind of a subset analysis of case controlled patients to see if there was any sort of trend. So the hospital clinical surveillance did at 2 hospitals that were the referral centers for the area. They prospectively enrolled all cases that met the case definition, which was new onset seizures or altered sensorium in the previous 7 days of a child less than 15 years old admitted to either hospital. They excluded anyone with a febrile seizure and then basically followed up any standard labs, tests, and imaging, blood glucoses that were done. And this also included a number of these patients who, as you might expect, got LPs. This is where it got a little bit strange. Their case control study was they originally planned that every other case patient who survived at least 6 hours past admission would be enrolled, and they would find an age and matched control sometimes in the 7 days around that admission. There was such high enrollment in June that the study was adjusted to every 4th enrollee. Like the actual number of cases spiked during that study. And then the controls, they originally were going to do 100 cases and 200 controls, but as we'll see, they kind of deviated from that plan. So the data that they were collecting, I thought this was like from an epidemiologic and like a clinical evaluation was like very well done. They looked at food consumption, food washing, water sources, literally any other exposure you can imagine, household characteristics and like socioeconomic differences in the region, as well as kind of your usual age, sex, gender, that kind of stuff. They also included the infectious workup if it was performed, and they uniquely had a couple of things that they worked with the CDC, our CDC, to kind of do extra testing on. One of those particular thing was they used their pathogen discovery laboratory, which sounds like a cool place to work. And they tested samples of the cases for pesticides and toxic elements, including they developed a completely novel assay to detect hypoglycin A and MCPG. So they were doing everything in their power to see whether or not this was there. And then they also looked at fatty acid metabolism biomarkers to see if beta oxidation was being impaired. And then, just because if that isn't enough, they also went and gathered some lychee samples. And so they went to the orchards and they collected unripe, ripe on the tree and ripe on the ground, to try and see what the difference is, in terms of their content. So, getting into the results of it here, 390 patients met case definition, and this was within like a month or so. Median age was 4 years, 55% were male. Many of them had evidence of malnutrition, but were reportedly otherwise previously well. And most, pretty much almost all of them, had sudden onset of symptoms within 24 hours of admission. So there wasn't like this building prodrome or anything like that. It was pretty acutely. And the cases, 66% of them started between 3 and 6 a.m. And classically were either like either altered mental status or seizures or kind of a mix thereof, including some episodes of status epilepticus. And of these 390 patients, 32% died. So pretty high mortality. What was interesting, they left this little comment, and I didn't know exactly how they came to it, but they noted that the cases didn't appear to be clustered. So it wasn't like a household outbreak. It was like one person in the household would have it, and then a completely unrelated household or area would suddenly have a single case. So that automatically is a little bit strange and kind of as far as the environmental exposure thing. Looking then, so for those 390 patients, they did 104 of those were their cases, and they got 104 controls. And they basically found that the exposures with significant association to getting the illness was lychee consumption, visiting a fruit orchard, and absence of an evening meal, which was a really unique little marker. And we'll come back to it because I thought this was a really cool part of the study. Socioeconomic index did not differ between cases and controls. Washing the fruits and vegetables appeared to be protective. And of those who they ingested lychee and ended up having an effect, it was mostly the ones that ate unripe fruit. So kind of like the ackee fruit, it seemed to be associated with the unripe fruit itself. There was no association with other vegetables or plants. There was no association with pesticides or insecticide use at the surrounding orchards. And there was no difference in like height, weight, anything else about these patients. So it really was pretty narrowly associated with lychee consumption. And then they took 80 of these case patients and had their samples tested at the US CDC, and there was no pesticide, metal exposures, anything like that. A bunch of them had CSF testing for infectious etiologies like encephalitis and meningitis, and all of that was coming back negative. And then 73 cases had urine sampling, found metabolites of hypoglycin A and FCPG. Most had abnormal organic acid profiles as well in the urine, and a lot of them had normal plasma acylcarnitine profiles. So kind of like what we talked about with about proate, this kind of indirect marker of carnitine abnormalities to kind of suggest our body's ability to deal with fatty acids had been distorted. And then the other important flip side, as far as kind of your burden of proof, none of the 15 controlled specimens had any of these abnormalities at all. So it was pretty much like an all or none. Then when they looked at the fruit, the unripe fruit contained about 2 times higher the concentrations of both FCPG and hypoglycin A than any of the ripe fruits. So basically, you can kind of tell, very overwhelming burden of proof for this article, that although there's only been a correlation, this is showing pretty good epidemiological and clinical evidence that consuming unripe lychee fruit results in a delivery of hypoglycin A and MCPG that leads to a failure of fatty acid metabolism, and kind of also adds to the evidence that it's unlikely that it's an infectious or other chemical causes. They kind of went into, in their discussion, discussing why was the mortality so high, and attributed a lot of it to the fact that this is a more rural area. There's a lot of critical care availability, kind of using that a little bit as a platform to say, hey, we need to boost our critical care potential in these regions as well. And then the other thing that was super interesting was that whole absence of an evening meal. So their thought was if the child who picked the unripe ackee or lychee and ate it, came home, wasn't hungry because they'd been eating the fruit all day, didn't have an evening meal, then was just going from like 7 p.m. until 3 in the morning with a dysfunctional fatty acid metabolism. That's why they suddenly get hypoglycemic. That's why their manifestations happen really early in the morning. Which I thought was kind of interesting. And this actually led them to say, during harvest season, one thing we can do right now while we're getting education out there is tell kids to eat. Because at the very least, if you continue to have sugar resources, you're avoiding all those problems. And then eventually do more work and trying to prevent any eating of the unripe fruits. So that was kind of cool. There was a lot of limitations. The biggest one obviously being correlation is not causation. This wasn't a prospective study that improved that there was this, but I feel like it's pretty convincing. There's a little bit of recall bias because a lot of this history or a lot of the epidemiologic stuff is of course history, and there's a potential for misclassification, but I don't know, seems that didn't get in too much of the way. And then the other thing, kind of the difference between the ackee fruit was the ackee fruit concentrations of their associated toxins were like 20-fold or more higher. This was just twice. And so it's like, why would that be so still kind of a very similar level of high toxicity? And so they do think it's worth looking into and trying to figure out more before we fully say that it's this. And then the other kind of bigger methodologic issue is they set out a protocol for a case control study and then like rapidly deviated from it, and then didn't actually meet their power kind of criteria. I think it's really convincing, but it is one of those where it's like that does kind of weaken their conclusions just a little bit. I don't know what's actually been done because of the article. I did a quick like news search and there are still reports of this as of 2019. And I don't know if that's because we haven't reported on it and it keeps happening, or if we haven't reported on it since then because we've actually done something about it. But obviously this has been a seasonal thing since the 90s. So hopefully there's nothing.
Yeah, another interesting, you want to call it hypoglycinate or hypoglycinate-like substance, and again, doesn't need to be a lot more concentrated. I mean, the thing that's a little odd is, it's obviously not the only corner of the world that harvests and eats lychee fruit. It's all throughout Asia, in fact, and this seems to be the only place that gets this constellation of diseases. So question why? What else is there? Is there a local genetic predisposition? Is there something about the soil, the geography, and the growing season that makes it? And almost all these cases just happen in June, this month of the year, in this corner of northeast India. So it's very odd, but that's why we study things like hypoglycinate from 30, 40 years ago, because it does occasionally pop up in related plants, fruits, vegetables, stuff. I think lychee, again, if ripe, is fine to eat, although I guess having hot cup of ice cream will get you through the night.
Did they mention if they had different separations, or were they all eating raw?
So it was mostly the association was with the unripe, just from the field.
Yeah.
I don't think there was any that was like specially prepared.
Were these kids harvesting it, or were they just part of the family? So they
They just
who knows?
I think it's interesting that a third of them didn't report eating it all.
Mhm.
Yeah,
The cases, like,
a lot.
yeah, 30-something% of them didn't eat it. So,
Yeah.
But I mean, I guess that does also raise like the area of India that grows a lot of lychee.
yeah,
Like, are there just lychee trees outside,
Everywhere.
and the kid goes outside and eats some, and the parents don't know about it because
They're
like
It's
The
their
number-
kid.
right, the number of times that I just went outside and ate oranges
Totally.
because they're outside of my house.
yeah,
Yeah, I would do the same thing if there was a lychee tree outside my house.
sure.
All right. Well, moving on, It's something else affects the pancreas is the French lilac, which most of you may not know much about, but it's been talked about since the Eber's papyrus of 1500 BC as the Galega officinalis, which is a lilac plant. And we have since figured out what is beneficial about it, and the first derivation of it was another notorious drug that we talk a lot about called fenformin. Here's a picture of fenformin and metformin. One is lipophilic, fenformin, one is hydrophilic. But tell us about a case and some review literature. Chris?
Yep, so kind of the introduction background, as Dr. Horowitz kind of said, the French lilac, otherwise known as the goat rue, was used to treat diabetes in medieval times in Eastern Europe. Guanidine was found to be the active component of this goat rue and was found to possess hypoglycemic activities way back in 1918. Guanidine's clinical use was limited secondary to its side effects of hypotension, atrial fibrillation, ataxia, and seizures. However, biguanides were developed from guanidine, and that is kind of one of the similar medications of fenformin and metformin kind of come into that. These were kind of introduced for the treatment of diabetes in the 1920s. And then another discovery in 1921 kind of lost the interest in it. Insulin was discovered in 1921, so it kind of, hey, we don't need to look at it orally. We got insulin and treat that. So the fenformin was introduced to the U.S. markets in 1957 for the treatment of non-insulin dependent diabetes. However, it was withdrawn shortly after, 20 years later in 1977, secondary to high incidence of lactic acidosis at therapeutic doses. The therapeutic doses ranges from 50 to 200 milligrams per day, but most people who ended up developing the lactic acidosis had an average of 123 milligrams per day. It is since been withdrawn in both the US and European markets, but is available worldwide, so it is something we kind of got to be aware of. And the cousin to fenformin, metformin, was used in Canada and Europe, and it was introduced to the US in 1995 after more than a decade of use in both Canada and Europe, with assuming minimal side effects if they approved it for us to kind of use at this point. So all of the biguanides, fenformin and metformin, can cause lactic acidosis, but just to kind of put it in a little bit of perspective, the incidence of lactic acidosis from metformin range from about 40 to 80,000 to 1, whereas with fenformin, it was cases were 1 in 4,000. So a lot more frequently encountered with this fenformin formulation as compared to metformin. Kind of similar, as we'll learn later, these real severe cases have almost a 50% mortality rate of them. And they go deep into a case report of a 67-year-old gentleman. He is a diabetic who was started on oral hypoglycemics from China 2 years prior to presentation. His initial complaints were just kind of weakness and questionable lesser consciousness is what they described it as. He noted that he was in his usual state of health basically up to the evening prior to him presenting. He developed some episodes of like diarrhea, and then it says he took an extra dose of his diabetic medications for his diarrhea. The next morning he developed kind of nausea, anorexia, and continued taking his medications. By that following evening, he was very lethargic and confused, and EMS was called by his neighbors. Initial vital signs on arrival were blood pressure of 200 over 110. This is EMS arrival, not still pre-hospital. 200 over 100, pulse of 96. He had respiratory rates of 18, no seizure-like activity. No change in mental status was noted after a bolus of D50. However, they finally were able to get finger stick glucose, and it read 20 milligrams per deciliter after the initial bolus. His mental status did improve after 2 additional ampules of D50. Then was transported into the emergency department. His medications that he was prescribed was fenformin and libenactamide. I guess that's a sulfonylurea that is used in China. He's got no other history, no other allergies, no tobacco use, nothing else really confounding his presentation. Lab workup, I'm just going to go over the notables because they give you a lot of lab work with this. He had a serum bicarb of 10.4. His glucose was 10. BUN of 26, creatinine of 1.6. He had an anion gap of 21.6. His urine glucose was 250. He had his first lactate was 24.6, which increased to 30. Initial ABG showed a pH of 6.91 with a PCO2 of 32 and a PO2 of 110. EKG was fine, CT was fine. They do know, although he initially appeared to be in no acute distress and was easily arousable, he deteriorated. They ended up intubating him. I would be scared to intubate somebody with that presentation. I was like, ooh. So they intubated for airway protection with hyperventilation, and then he was given a dose of activated charcoal, and then bicarb was given a total of 19 ampules over the 12 hours. I guess hemodialysis was recommended by the poison center that was contacted. However, the case kind of improved and it didn't actually require dialysis. 12 hours after presentation, his lactate had fallen down to 5.6. His pH was 7.27. And then at the day of discharge, which was 6 days after presentation, his acid-base status normalized and he returned to his baseline mental status. So, what caused this? His fenformin. So what fenformin is it's the biguanide that we're talking about, and it's used to treat non-insulin dependent diabetes. What it's thought is, no you. So with non-insulin dependent diabetes, there's a increased resting glucose levels with them, and they thought these medications can kind of benefit in multiple different ways. They inhibit the hepatic gluconeogenesis, so decrease glucagon production while also increasing peripheral uptake of glucose. Sorry. Increases intentional uses of the glucose as kind of their side effects. However, their thought of process. They also do not have any effects on glucagon, somatostatin, growth hormone, or cortisol levels. However, in contrast to sulfonylureas, which are associated with profound hypoglycemia, these medications do not cause any severe hypoglycemia, even in the overdose settings. Quote unquote. Doesn't say, not in reference to your papers back in 1995. So how do they actually work? Like, what's their mechanism? So it basically, the basal level of insulin on normal healthy people would prevent any catabolism, fat breakdown, or muscle breakdown. However, that's not the case in these fasting diabetics. Breakdown of muscles basically increase alanine concentrations, and then that is and other amino acids, which are then converted to pyruvate, kind of increasing your pyruvate concentration. Gluconeogenesis is inhibited, so pyruvate itself accumulates, isn't shot back up to make glucose. The oxidation of fatty acids also decreases your NAD plus and increases your NADH. So you have an increase in your NADH to NAD plus ratio, which further basically inhibits the production of acetyl-CoA. It's also inhibiting the pyruvate dehydrogenase, so pyruvate can't get made into acetyl-CoA to go into the Krebs cycle, and basically it just funnels pyruvate over to lactate, causing these real impressive lactic acidosis with all these. There's various factors that kind of should be considered when you're worried about this presentation along with the severe acidosis. Most the biguanide, especially metformin, is renally cleared, so any renal instability or insult can kind of cause this to accumulate and prolong these effects here. Cimetidine, I guess, is another medication that will also reduce the clearance of metformin with this. And so they kind of, after going over the mechanism, how it actually causes its toxic effects, they go into reviews of these. In a review of 76 individuals, Dembo is the author of this one. Basically, it says that your predominant symptoms are going to be nausea and vomiting in 83% of the cases. Then you have Kussmaul breathing and altered level of consciousness in about 70 to 78% of the presentations with these toxic effects of this. Lufta was another review of 330 patients that had the biguanide-induced lactic acidosis. Again, most common complaint was nausea and vomiting. Patients, so there was basically a range of level of consciousness that they noted. There was decreased level of consciousness noted in 177 of the 212 patients. However, the ones that actually had this documented, it just seemed to correlate kind of with very low glucose or very high levels of their BUN. So kind of the things that we expect to cause altered mental status. 35% of them had renal insufficiency. So kind of, again, shifting away from the clearance of this. Another study, LUFS, is basically talks about the acid-base status, that you can kind of look into these and breaks it down to what the median survivability, what the median dose was, or median lactic acidosis was, what the median dose of people who died, and what the median dose of those that survived. So with a median dose of lactic acid overall was 16.9. In those that ended up dying, the median lactic acidosis was 18.5. And then for the ones that ended up surviving, it was 15.6. Does the same thing for the acid-base status with pH. So the average was a pH of 6.95. Those that died was a 6.91, and those that ended up surviving was a pH of 7.0. So these are pretty profound.
Which is also what we see with metformin, of course.
And that was, so I will skip over that since we know that that is no longer true. So then treatment for these overdoses, I was going to say, or just the toxicity in general, because these don't necessarily have to be overdoses, is basically supportive care. They talk about ventilation and circulatory control, so give them IV fluids. They talk about intubating to help clear the lactate. I don't know how Intubate and hyperventilate to provide respiratory support and quickly improve your pH and acid-base status.
But it's not lactic from a poor perfusion standpoint.
Yes.
Right.
So,
So if people just talk about type A and type B lactic acidosis, type A is hypoxic ischemia, crushed entry, dead valve, dying tissue, lactic acidosis. This is not what this is. It's just type B. Metabolic switching of pyruvate to lactate, shunt lactic acidosis.
I think that is the approach we would take nowadays.
Yeah.
They do talk about insulin does appear to have some increased survival in a couple of the articles that they cite here. The bicarbonate use is controversial. I was going to say they do kind of talk about the theoretical concerns of worsening your acidosis status with the bicarbonate infusion. However, they're basically recommending it for anybody with a pH of less than 7, because that was kind of your average pH of people that ended up surviving. Let's try to get your pH at least above 7. Hemodialysis can kind of help with removing the lactate. They also say it can remove other ketones in there, such as acetoacetate and beta hydroxybutyrate, and kind of help with your generalized acid-base status. They also talk about a different medication, sodium dichloroacetate, kind of to help with that. I guess that increases the activity of pyruvate dehydrogenase. I was going to say, I'm not very familiar with that, and it doesn't seem to really pan out with that. So with these really high lactics in people that present to the emergency department, these are one things you definitely have to keep on your differential for these patients. kind of with how he initially presented, he was alert, he was able to talk to you, their mental status is still intact. He ended up deteriorating, but that's kind of one of those that you'll see a lactate that is out of proportion to your physical exam.
Yeah, just a reminder, yeah, that metformin was sort of the more frequent bad actor with metabolic lactic acidosis. Metformin still is not free of it, and it's dose responsive. It's, although taking metformin at the right dose with good monitoring is usually not associated with it, but at high doses and overdoses, we definitely see the same thing. And again, I put in a plug for hemodialysis is the treatment of choice, not bicarb or any of these other things or dental hypertension. It's to clear both the lactate and the metformin itself. So, I mean, metformin might have been an okay antidiabetic medicine. I just think they needed to figure out what the real safe dose was. I think they put a dose on the market that was unsafe, and they didn't want to go back and say, well, maybe a tenth of it is the right dose. I don't know. Gone into history. So moving forward a little bit, it's sort of a classic study for an antidote, and that is only about 9 patients involved for us to be convinced that maybe it works. But it does work for sulfonylureas. That's the drug octreotide, and we're going to have tell us about this one.
So this is a study from 1999 looking at octreotide as an antidote for sulfonylurea-induced hypoglycemia. And the goal was to determine whether or not octreotide can decrease the glucose supplementation requirements and decrease the number of hypoglycemic episodes in patients who have sulfonylurea overdoses. This was a retrospective chart review that occurred through the years of 1995 to 1998. And they compared patients who ingested 2 sulfonylureas, glyburide and glipizide. A little bit more about their background. Sulfonylureas as a medication class cause depolarization of pancreatic beta cells and facilitate preformed insulin release. So there's extra endogenous insulin release that's sustained and suppresses glucose values. Why octreotide might be helpful to these people? Well, before using it, they required much more frequent, intense glucose monitoring, perhaps with a central line, IV dextrose administration, glucose supplementations and measurements every 20 to 60 minutes. And the mechanism of octreotide can help with that because it is a synthetic octopeptide analog, similar to the endogenous human hormone somatostatin that causes inhibition of secretion of insulin, glucagon, growth hormone, gastrin, a number of hormones. So a little bit more about the methods of this study. What they included were patients with a history of a sulfonylurea ingestion, and then at least one documented episode of hypoglycemia after initial glucose testing. And they enrolled only 9 patients. And it's unclear whether they were single agent ingestions or multiple. I have to assume they were single agent ingestions. And they defined hypoglycemia as a value less than 60 milligrams per deciliter. They called the p-value of significance 0.01. And they used something called a failure time analysis, basically seeing at what point would their treatment fail, at what point would the patient become hypoglycemic again after administering octreotide. And the endpoints of interest to them were the number of hypoglycemic events, the amount of glucose needed to resuscitate the patient, and they measured the risks of these hypoglycemic events occurring. The different patients, the 9, were evenly spread on ingestions of glyburide versus glipizide of varying dosages. The patients themselves were male and female of varying ages. There's a lot of varying data in this cohort. including time of ingestion between 32 and 4 hours prior. The octreotide dosing used as interventions also varies quite a bit. Some patients receiving 100 micrograms subcutaneously for one dose, some getting 50 micrograms subcutaneously, then subsequent additional subcutaneous doses, and some patients getting on octreotide drips. But the figure showing the time course of hypoglycemic events in octreotide dosing on page 136, I think is the most telling result. And it's very visually compelling. And for those listening who can't see, on the left side, we're seeing hypoglycemic events before octreotide dosing, and it is absolutely peppered with arrows indicating that their glucose is below 60. And then a big center line showing the octreotide therapy being started. And then there is virtually no hypoglycemic events after the octreotide dosing. 2 patients did have recurrent hypoglycemia out of the 9. It's unclear how low they went, and those hypoglycemic events occurred at the very end of the time course that the study monitored for. So we don't know what happened after that, or how many more hypoglycemic events that potentially could have been. But I think the study is, very compelling in seeing the significant drop off of those hypoglycemic events. Before octreotide, the mean was 3.2. Afterward, the mean was 0.2. And that is a p-value of 0.008. The number of ampules of 50% dextrose needed before octreotide was 2.9 mean, and afterward was 0.2. The risk of recurrent hypoglycemia before the octreotide treatment was 27 times greater. So this is a small study, only 9 patients. And as I mentioned, it's unclear if this was single agent ingestions. I'm imagining that's who they would select. Comorbidities aren't really well described. Other medicines the patient might have been on isn't described. And then just the number of glucose checks that occurred after the octreotide dosing, I wonder about as well. If people believe this would work, maybe they get a little bit lazy about checking afterward. But it's hard to know what happened after. So, if we can trust the data points that we're seeing, octreotide is clearly helping people from becoming hypoglycemic due to sulfonylurea overdoses.
Yeah, this is sort of a breakthrough. It was done in the University of New Mexico, where they were doing other experiments on octreotide, and the folks in the ER toxicology group there said, wait a minute, if you're using this for this other diabetic usage that may work, how about for these sulfonylureas? And they tried it. There was what I call the DORM study that was done just before that, where they took healthy medical students and undergraduates. They gave them a sulfonylurea, and then they checked their glucose very so often, checked their insulin levels, and then gave them octreotide, and octreotide blocked it all. And then unfortunately, where they had a problem is they let some of these people go back to their dorm, and then 1 or 2 of them actually got hypoglycemic. I think the big difference between that and this one was they didn't let any of these people eat, and I think normally someone would come in with hypoglycemia after we got them awake and alert, we feed them all. So that's like the good news is that's what we're doing. And they mentioned back then in the 1990s, the cost of this was very inexpensive, and it still remains very inexpensive, like $11 a dose, and it can be given sub-Q. We don't even get everyone gets one to treat these sulfonylureas. And for 20 years, sulfonylureas were the drug of choice, really, along with metformin for type 2 diabetes. So we saw a lot of people getting either taking too much of it, not eating, or overdosing on it again. Family hypoglycemic. And this was an inexpensive, very nice little fix. Just for everyone, the diagram, this is sort of the simple version of the diagram. There's a much more elegant version of the diagram inside Gold Franks, where basically there's this potassium channel that's fueled by ATPase that is blocked by the sulfonylurea, and it coexists with a calcium channel that's a influx of calcium causes insulin release. So when you turn this off, you essentially turn off the beta islet cell So it can't respond anymore, no matter what the glucose levels are. Of note, before, so octreotide was used for this indication for years and years and years. There was another drug, diazoxide, that was an antihypertensive medication that was used for the same effect. The problem was it caused hypotension and volume depletion. People were very skittish about using it in diabetics, so it didn't gain widespread use. And we'll talk about something new in a second with that medication. But this was, its mechanism of action. Sort of the good news is we're not really using a lot of sulfonylureas anymore. There's 3 or 4 other both oral and weekly injectable diabetic medicines that have worked then push sulfonylureas out of the way versus hypoglycemia along with them. We mentioned you don't get hypoglycemia with metformin, although we've had a couple of recent cases where, lo and behold, you do something long enough and watch it close enough, it will happen. Big mega overdoses of metformin were associated with not only hypoglycemia, but hypothermia and laughter as well. So finally, finish up with Tiffany telling us from a ripped from a hot off the presses article, because I don't want to say we were living in the 1970s anymore. It's 2025 diazoxide, a 40-year-old plus drug that was used for hypertension, has been used for new indications now. So tell us about the problems that occurred in this interesting case report here.
Yeah, so diazoxide is now the first line treatment for children with hyperinsulinemic hypoglycemia. So it works when taken orally, it works by raising blood glucose levels by suppressing insulin release from pancreatic beta cells. So it prevents the hypoglycemia that occurs with different conditions that like hyperinsulin tumors or genetic conditions. Interestingly, the IV form of diazoxide actually works on the potassium channels. It activates them and enhances cell membrane permeability to potassium ions and causes a vasodilatory effect on smooth muscle and peripheral arterioles. So then actually lowers blood pressure, but the oral form does not have any effect on blood pressure. So I thought that was kind of interesting. So this article, like you said, is from 2025. It's a case study of diazoxide-associated hyperglycemia. So it's a critical case that precipitating hyperosmolar hyperglycemic state in a child who was taking diazoxide for a medical condition. So this was an 8-year-old female who had a genetic disorder involving glucokinase, resulting in hyperinsulinemia. She had presented to the emergency department in hypovolemic shock secondary to severe dehydration. She was having signs of end organ damage with encephalopathy, electrolyte derangements, dehydration, and her point of blood glucose was greater than 600 milligrams per deciliter on 2 repeat checks back to back. We'll get into that case a little bit more. Essentially, she was, treated in the PICU, a diazoxide level that was obtained during admission. Not the first one, but actually the second one. I'll explain to you guys why. Showed that it was super therapeutic by quite a bit, which they believe was kind of implicating this hyperosmolar hypoglycemic state. So I'll go into the case a little bit. Let's see. Oh, and with this condition, so this had been previously described in infants and then in adults, this HHS occurring as kind of a severe adverse effect of diazoxide therapy, but never in children. So this was kind of a new thing that was found for this case study. So I'll go to the case. So this was an 8-year-old, like I said, 8-year-old female. So she had originally presented with severe dehydration. She had gotten a G-tube placed and was getting feeding through that, but was having intolerance and emesis. So kind of it was baseline dehydrated prior to this presentation. She had been on this diazoxide for twice a day for quite a while, with no issues. But they were starting to give it through the G tube. The G tube was placed 7 days prior to her presentation. Initially, she presented in hypovolemic shock, likely secondary to severe dehydration, had some encephalopathy, minimal responsiveness to tactile stimuli. Like I said, at that point, her glucose was checked on 2 checks. It was greater than 600 on the reader. She was originally treated with aggressive fluid resuscitation, which did not improve her hypotension or mental status, and her glucose remained greater than 600. Her blood pressure did respond to a norepi infusion, and she was headed to the PICU. She had severe electrolyte derangements as well, likely as a result of this HHS, but also her dehydration. So her sodium level was actually reading 106, corrected for her hyperglycemia, it was 138, so not quite as bad. But her potassium was 2.5, her chloride was less than 60, bicarb of 20. And her glucose level on the lab value was 2,105. Quite elevated, yes. She also had an AKI with a BUN of 107 and a creatinine of 3.99 initially. And let's see, beta hydroxybutyrate was elevated to 4.24, and her urinalysis had trace ketones and large glucose. She was in a mild respiratory acidosis with pH of 7.24 and a CO2 of 56. Her liver transaminases were within normal limits. So based on this constellation of electrolyte abnormalities and the severely elevated glucose concentration, poor response to fluid resus, they diagnosed her with HHS. So her course, she was in the PICU, endocrinology was consulted. She did eventually respond to aggressive fluid resuscitation. They talked about, they did not start her on an insulin drip because they were worried that they would overcorrect too quickly with her kind of baseline hyperinsulinemia. So they just treated her with fluid resuscitation, and things started to normalize over 48 hours. Let's see. She no longer needed vasopressors. She ended up downgraded to the floor once her mental status improved after about 3 days. At that point, they managed to get a diazoxide level, but it wasn't obtained until day 3, which was about 53 hours after her last reported administration of the medicine. So it wasn't super helpful value-wise. They got it back at 13. Let's see. What's the little U? I can't remember. Micrograms, thank you, per milliliter. And they had estimated that for her, based on her weight and everything, her expected range, therapeutic range, would be between 31 and 57, roughly. So she was definitely low, but again, not a good value to look at yet. So when she was downgraded to the floor after day 3, her diazoxide was reintroduced at the home dose, which was 150 milligrams BID through the G tube. On day 4, so only 1 day after her hypoglycemia, let's see. Oh, they started it again because on day 4, hypoglycemia recurred, but then they had to discontinue the diazoxide again on day 7, 3 days after reinitiation, because she developed hyperglycemia again, and her blood glucose at that time was 743. She also had tachycardia, hypotension, and altered mental status. Readmitted to the PICU, and again treated for HHS with fluids. This time, her blood glucose remained above 600, and so they did end up giving her exogenous insulin via an infusion. Her second diazoxide level that was obtained at that time, 3 days after reinitiation of diazoxide, was 97 micrograms per milliliter, so well above the range that they would expect her the therapeutic range. And then the rest of her course was fairly uncomplicated. She was discharged 22 days after admission, and on a lower dose of diazoxide, so 120 milligrams twice a day rather than 150. And 2 weeks after discharge, she was seen for reevaluation, had stable blood glucose, and they did not need to make any more changes to her diazoxide dosing. So, some of the discussion. So they talk about diazoxide as it's a commonly used drug to manage hyperinsulinemia of various etiologies. It raises the glucose concentration by stabilizing the sulfonylurea receptor subunit of potassium ATP channels on pancreatic beta cells to allow potassium efflux, membrane hyperpolarization, and suppression of insulin release. It is mainly eliminated in the urine by the kidneys, and it's typically slow given its high protein affinity in the blood. So it has a relatively long half-life, ranging from around 6 to 27 hours in pediatric patients. And then again, that is exacerbated by patients that have a decreased creatinine clearance. So if you remember in this patient, she had a pretty significant AKI, which would have made the clearance much slower. They talk about how it's difficult to interpret that first diazoxide level, but luckily, unluckily, she ended up having this again, so they were able to get a more accurate diazoxide level and determine that it was probably elevated prior to, even though there's no number that we can actually show for. And then they talk about, lowering the dose and how that did seem to work. They had a very broad differential for this patient, including DKA. There was no metabolic acidosis or history of diabetes, so it didn't really support that. They were concerned that maybe there was a surreptitious administration of diazoxide, but the family were very reliable. They denied any excess administration, and she had taken the same dose for years prior to this happening. They also considered that maybe the concentration of the bottle was unintentionally increased, but diazoxide is a manufactured solution, it's not compounded, so low likelihood of that happening. So they hypothesized that her serum steady state concentration was predisposed hyperglycemia, further worsened by the development of severe dehydration, study of nausea, vomiting, and the AKI. So that was actually what caused her to develop the HHS this time rather than a year prior that she'd been taking it. And then they say that, this is something to keep in mind. HHS is a potentially lethal side effect of diazoxide, and especially in children, and that there may be utility of monitoring the serum concentrations of diazoxide to identify those at risk of hyperglycemia, and then close blood glucose monitoring during acute illness to prevent this kind of presentation.
Yeah, I think that's the key thing. You have a disease of your pancreas, whether it's under or over release of insulin, you probably need some kind of glucose monitoring to see how things are doing. And that was kind of interesting that this drug, which was old and used for hypertensive crises urgency back in 40 years ago, was repurposed for this sort of genetic disorders which involve hyperinsulinemia, suppress insulin release, and finding that it doesn't really have any antihypertensive effects if you give it orally. So it's kind of neat in that way, and it's probably super inexpensive because it's a really old drug. But it does work the same way in the pancreas as octreotide does. I guess I'm thinking sort of out of the box here. Someone takes the sulfonylurea, they can take DO. I don't see why we couldn't give them a dose of oral diazoxide, which may be cheaper. I don't know. Depends. Or just a sub-Q shot of octreotide, which is also pretty inexpensive. So either of those are options, I guess. I think we should also all be aware that hyperglycemic hyperosmolar states exist. They're up there with DKA, a little less common, and we should be aware and treat them. We were sort of maybe grimacing a little bit the fact that they withheld the insulin from the first episode with a glucose of 2,000 something. I think glucose is, obviously the first phase is to resuscitate them volume-wise, again, lots of crystalloid. But at some point you do need to start some insulin to start driving that sugar intracellularly and out of the body. Anyway, a variety of toxins that all work on the sugar or the pancreas for you to be aware of. And that concludes our July Journal Club. Thanks everyone for nice presentations. Thank you.